Mr. Thompson, would you
Thank you, Mr. Chairman. I have some questions. First, I just want to weigh in on the multi-campus issue. And one of you had mentioned that you know that this is of great importance to certain members of Congress. I just want to clarify that. I think this is very important to certain areas that members of Congress represent. And I want to figure out some way to get beyond the technical issues that you had referenced, because some of these hospitals are set up in a way that if we don't recognize this are going to be left out, and I think that hurts the overall goal that you and all of us are shooting for. There's no need to respond. That I just think it's important that you know where we're coming from. I'd like to take up where my friend Mr. Johnson left off on the rural stuff. There's just vast areas of the country that are lacking in infrastructure, period. So you could have a hospital in a rural area that very much wants to do this and is willing to do their part in doing it, but just the lack of infrastructure in the area is a deterrent. I'd like to hear your thoughts on how we deal with that.
Well, my boss, Secretary Sebelius, is very familiar with rural areas and their problems. She's a former governor of Kansas, and she has actually convened a meeting of a Health Information Technology Rural Task Force. That's going to have its first meeting next week. It's the Secretary of the VA, Secretary of Agriculture, Secretary of Commerce, and the Federal Chairman of the Federal Communication Committee are all going to participate. All those agencies have resources available to help provide technical infrastructure in rural areas, and we're going to be trying to see how combined we can accelerate access to the broadband and the technical needs of exchange in those vulnerable rural areas.
There's a need for a huge investment in this area, and I think we're only fooling ourselves if we think that we can move towards full compliance with HIT and accomplish all the good things that we want to accomplish without making an investment here as well. On the further on the issue of rural providers and individual and small group providers, and I'm interested in knowing how do we increase their ability to participate in this, and do the small guys even know about the incentives that are out there and how they can get them, and I'd like to know how you're going about getting the word out. Are you advertising? Are you doing house calls? How are you doing it?
Go ahead first.
Again, a very big and important question, and one of the reasons why we realized we had to do this in phases to be fair and to accomplish our goals. Our regional extension centers are a critical arm of this effort. We have 60 of them. We've committed over $700 million to them. In addition, they have $50 million in support that will include the kind of materials you're referring to. That is the development of communities of practice, collaboratives, places where people will come together and learn how best to get the information out. All those regional extension centers will have the ability to work with physicians in local areas, to talk with them and give them advice about where to find records, what kind of records would best serve their needs, actually to deploy people to their offices individually to help them get up and running on an electronic health record, and then to help them figure out how to change their office around once they've adopted a record. Every geographic area of the country is covered by at least one regional extension center.
Can we get updates on what those areas are doing and how it is, how their outreach is working in particular
Absolutely.
areas? And then just one last question, Mr. Trankley. Can you explain why the actuarial analysis estimate of the actual incentive payments that are being utilized has such a wide swing? I think the numbers I saw were between less than $10 billion and almost $30 billion.
Yes, the differences are basically because of the potential growth rates. We looked at, the actuaries looked at some different models, and they determined what was at low end and what was a higher end. So at the low end, if you look at the what we put into the impact analysis, was that in 2011 it would be as low as 10% or as high as 36% in 2011, rising to a 36% to 70% in 2019. So they wanted to look at that and also look at the information we got back from the commenters on what some of the costs, some of the changes that need to be made to get up to speed. So there was a variety of factors they took into account. Also, they had to take into account the potential impact of the Medicare payment cut as well.
And so this is still the projections?
Based on our impact analysis, yes, these are the current projections that we based on information to date, studies that have been done, and basic actuarial projections. Obviously, as David said, not only does ONC have an extensive regional outreach effort going, they're also working with CMS. We're utilizing our existing outreach efforts along with coordinating with ONC to try to get to the high end or above rather than the low end. But for the purposes of the regulation, we have to put in both ends.
Thank you.